Hi, and welcome back. In this physiology lecture, we're going to talk about blood. This is a pretty simple and straightforward chapter, so hopefully you enjoy it. The only real complex idea is the clotting cascade, which we'll talk about at the end. Alright, so blood. We know blood as the fluid that flows through our blood vessels. Now the function of blood is obviously to transport things throughout our body. And it transports oxygen and nutrients to the cells. Okay, so oxygen from the lungs to the cells, and nutrients such as lipids, proteins, and carbohydrates to the cells so they can use it for cell metabolism. And then the cells produce waste products during cell metabolism, such as carbon dioxide and nitrogenous waste, that the blood is going to carry away from the cells to organs that will get rid of this waste, such as the lungs, so that you can exhale the carbon dioxide, and the kidneys, which will excrete all your nitrogenous waste. The other thing that the blood transports is our hormones. We learned about that hormones are chemical signals that travel in the blood, from the endocrine gland that secretes them to their target cells. Some other things that blood does is it actually plays a role in maintaining body temperature. Blood is mostly water, and we learned about that water has a high specific heat, so it can absorb a lot of heat and without increasing in temperature very much. It absorbs heat, and then also your blood, by shunting blood to various organs or away from certain tissues, you can distribute that heat, and your body does that. We learned about in our last chapter when we talked about blood vessels, how you have your precapillary sphincters and your arterioles that can contract or vasoconstrict so that less blood goes to a tissue, or vasodilate to allow more blood to go to a tissue. So if you want to warm a certain part of your body, you can vasodilate to have more blood flow to that area, or move blood from a certain area that doesn't need as much heat. And the blood also plays a protective role. One is it prevents infection. All your white blood cells travel through the blood, and if you can increase blood flow to an area where there's infection, that brings more white blood cells to that area and allows you to fight off that infection better. That's why when you have inflammation, it's warm and it's red, because you've increased the blood flow to that area. We'll learn a lot more about the process of inflammation in our next chapter, Body Defenses. The other thing blood does is there's a lot of proteins, plasma proteins in the blood that play a role in blood clotting. So if a blood vessel is damaged, the clotting cascade will get initiated and you'll form a clot in that blood vessel. And that's going to prevent blood or hemorrhaging from that blood vessel. Why is it important not to lose blood? Well, if you lose too much blood, your blood pressure will drop, and then certain organs will not be getting enough blood, obviously. Also, your kidneys can shut down because they need blood pressure to filter out the waste in your blood. Alright, so let's look at what blood is made out of. We can kind of divide blood into two segments and then sub-segments from there. So your blood is your only liquid tissue. And it's a liquid because it has what we call plasma, which is basically the liquid part, which would be the matrix of the tissue. And then the specialized cells found in the plasma, which we would call your formed elements. Okay. So plasma is the fluid, and it's mostly water. 90% water is what makes up plasma. And then there's some things dissolved in the plasma. The main thing is you have a lot of proteins found in the plasma. And we'll talk about these different proteins on our next slide, but some examples of the proteins that you might be familiar with are albumin, antibodies for your immune system, and then clotting proteins are all floating in that plasma. The other thing that's dissolved in the plasma is you obviously have a lot of electrolytes, like sodium and potassium, calcium, which we've learned are important in nerve impulses, muscle contraction. Magnesium is important in muscle contraction. Chloride, bicarbonate, which we learned way back when we learned about chemistry, that bicarbonate plays a role in buffering the pH of the blood. So plasma is the fluid portion. You may have heard of serum, And you might not be familiar with what the difference between serum and plasma is. The only difference between serum and plasma is that plasma contains the clotting proteins. Serum does not. Then you have all the formed elements, which are the cells found in the blood. And we know we have your erythrocytes, which are your red blood cells. You have your leukocytes, which are your white blood cells. And then you have your platelets. Technically, platelets are not cells. They're fragments of a cell, which we'll talk about. But we still consider them a formed element. So if you looked at how much of the blood is plasma, how much of the blood is formed elements. Well, for example, when you draw blood, we call that whole blood. And for example, if you wanted to run a blood test, blood would get drawn as whole blood, and it would go to the lab. And in the lab, they would centrifuge your blood, and the centrifuge is just a machine that separates things in a fluid by weight, so that whatever's heaviest will drop to the bottom. And so the blood will separate into its components. And what you find is about 55% of your blood is plasma, and it's a straw-colored fluid on the top. And then you get what we call a buffy coat, which is a really thin layer. It's kind of white or off-white. And that's where you would find your white blood cells, your leukocytes, and your platelets. And they make up less than 1% of whole blood. Percentage-wise, you don't have too many leukocytes and platelets compared to the other components. And then you would have your erythrocytes, which are your red blood cells. Your red blood cells make up about 45% of your whole blood. And looking at the percent of red blood cells is a very common blood test clinically. It's called your hematocrit. So your hematocrit is the percent of red blood cells you have. So if your hematocrit is 28, that's very, very low and you're anemic compared to having a hematocrit of 45, which is normal. It's a little less for females, males about 45. So what we're going to do is we're first going to look at the different types of proteins you have found in the plasma, and then we'll go through and look at the different formed elements. We'll look at erythrocytes in detail, we'll look at the leukocytes in detail, and then we'll look at the platelets. So let's start with the different types of proteins you'll find in the plasma. And the purpose of these proteins, or one of their main roles, is to maintain osmotic pressure. Remember, we learned about in our blood vessel chapter that fluid leaks out of the blood into the tissues based on hydrostatic pressure. But then you reabsorb at the venous end some of that fluid because the osmotic pressure ends up being greater than the blood pressure. Well, that osmotic pressure is really important because otherwise, if you didn't have it, you'd leak fluid out into your tissues and your blood pressure would drop. And so would your blood volume and then blood pressure would drop, which is very dangerous. How do they maintain blood pressure? This goes back to remember your laws of diffusion. So here's my blood vessel, and this is my extracellular fluid out here, or my interstitial fluid. And then here's my plasma, right? In the blood vessel. That's nay. Okay, so there's my plasma. Now I have a lot of protein in the blood vessel, because that's all my plasma proteins. So they're all in here. Plasma proteins are considered a solute in that fluid. So I have a lot of solutes found in the blood. Now in the extracellular fluid or interstitial fluid out in the tissues, I have hardly any protein at all. So what that means is that creates osmotic pressure where fluid wants to move into the blood. Water wants to move from its higher concentration to its lower concentration. That helps maintain blood volume. Okay. Now what happens if you didn't have those plasma proteins? So if we were to remove these and the solute levels shifted to where I had more solutes in the interstitial fluid than I had in the blood, That's going to shift my osmotic pressure, and now fluid's going to leak out of the blood. Okay, so that's what's dangerous. So having those proteins in the blood that can't get out of the blood, because their proteins are too big to move out of the blood vessel, it maintains that reabsorption at the venous end to maintain your blood volume and blood pressure. Now some people that have liver disease, because a lot of your plasma proteins are produced in the liver, so people that have liver disease, they might not be producing enough plasma proteins, and what will happen is fluid will shift from the blood into the extracellular fluid or the interstitial fluid, and you'll get swelling of the tissue, or you can end up with losing blood volume. That's what we mean by maintaining osmotic pressure. Now, of your plasma proteins, the majority of them are albumin. So 60% of the plasma proteins circulating in the blood would be albumin. Albumin plays a role in not only maintaining osmotic pressure, but they can also transport certain substances. We learned about substances that aren't water soluble. They won't travel in the blood very well, so they have to be carried in the blood by a carrier. So albumin can act as a carrier for such things as bilirubin, which is a byproduct of red blood cell destruction, which we'll talk about, and things like bile salts, which get reabsorbed in the intestines and need to be carried back to the liver. We'll learn more about this when we do digestion. Albumin also can carry some hormones, such as your thyroid hormones. Another type of plasma protein you'll find are called globulins. That's a general term for them. And there's 3 types of globulins. There's alpha, beta, and gamma globulins. Now your alpha and beta globulins usually play a role in transporting hormones. They can transport cholesterol in the blood and iron in the blood. For example, there is a globulin called transferrin, and that's its name, and it carries iron. Or you learned about thyroid binding protein in lab. That's a globulin that carries your thyroid hormones. The other thing that falls under alpha and beta globulins are proteins that are inactive in the blood, and they get activated later on to trigger a response. So you learned about, remember, your renin-angiotensin-aldosterone pathway? Well, angiotensinogen, remember, is a protein that is in the blood, and it's considered inactive at the time, and remember, it gets activated by renin into angiotensin 1. So angiotensinogen would be an example of a alpha-beta globulin, and all your clotting factors, which are proteins in the blood. Now gamma globulins are your antibodies. So antibodies are proteins that are produced by B lymphocytes, and these proteins play a role in your immune response, which we'll learn all about in our next chapter. Another type of protein you'll find in the blood is fibrinogen. Now fibrinogen, see the GEN on the end? It's an inactive protein that then gets activated. Fibrinogen gets activated into a protein called fibrin, and fibrin is the protein that makes up a clot when you form a blood clot. So these are just examples of the different type of plasma proteins you would find in the plasma. Alright, let's look at our formed elements, and we'll start with erythrocytes, also known as red blood cells. Now you should have learned in anatomy what a red blood cell looks like. We know that they're round. We say they're biconcave, and what that means is, well, they're concave on both sides. That's what it means. So they kind of look like a donut without the hole. Okay, it's the cross section. They're thicker on the outside rim, thinner on the inside. Red blood cells are interesting. A mature red blood cell that's circulating in the blood contains no nucleus and no organelles. Now it had a nucleus when it was developing in the bone marrow, but towards the end of development it spit its nucleus out because it has to have nucleus in it in order to do protein synthesis, right? So it had a nucleus during development when it was forming, but then when it goes into circulation, before it goes into circulation, it spits the nucleus out. And the reason is because it makes room for all the hemoglobin, which is the protein that is inside a red blood cell. So a red blood cell is basically filled up with hemoglobin, which is a protein that carries the oxygen. What you will find in a red blood cell is some enzymes just in the cytoplasm. So basically, it's a cell filled with hemoglobin, it has some cytoplasm, and it will have enzymes to carry out glycolysis, because red blood cells do need some ATP. They don't need much ATP, so they don't have mitochondria, for example, to carry out the electron transport chain. They just have the enzymes to carry out glycolysis to make some ATP. And then they have an enzyme called carbonic anhydrase, and you learned about carbonic anhydrase when we did chemistry. It's the enzyme that converts carbon dioxide, basically carbon dioxide and water, combine to form carbonic acid, which then dissociates into bicarbonate and a hydrogen ion. Remember your buffering equation that we learned about in chemistry? So we'll learn more about this when we get to respiration, or your respiratory chapter, because we'll talk about how red blood cells carry oxygen and carbon dioxide in more detail. Now, the other thing that's interesting about red blood cells is because they don't have a nucleus, they can't repair themselves. So they only live about 120 days, 3 to 4 months. And then what needs to happen is they'll be destroyed. And the main organ that destroys red blood cells is the spleen. Okay, the spleen filters out old red blood cells and basically recycles everything. So the amino acids that make up the hemoglobin will be recycled for protein synthesis of other cells. The heme group, which we'll talk about, will get broken down into what we call bilirubin. Okay, and the iron can be recycled too, or stored in the liver. The spleen is the main organ that breaks down red blood cells. Now, some people have their spleen removed. So what happens then? Well, the liver can also play a role in breaking down red blood cells. So in that case, the liver would take over. So I already kind of mentioned this stuff in the previous slide, but the main function of erythrocytes is to transport oxygen. Red blood cells carry oxygen from the lungs to the tissues. It also, though, carries carbon dioxide to a lesser extent. Okay, but carbon dioxide can be carried on erythrocytes. We'll talk more about how they transport the oxygen and the carbon dioxide again when we get to your respiratory chapter. And this protein, hemoglobin, is what transports the oxygen and the carbon dioxide. And what it's made out of, one hemoglobin molecule would be made up of 4 proteins, okay, folded into their tertiary structure. And we call those 4 globulin polypeptides, and each polypeptide has what we call a heme group in the center that you're seeing here in orange. A component of the heme group is iron. So without iron you can't form the heme group, and it's the heme group that carries the oxygen. Carbon dioxide will be carried on another location on the hemoglobin. So erythropoiesis is the process of producing new red blood cells. Because I told you red blood cells only live 120 days and then they're destroyed. So your body has to constantly be replacing those red blood cells that get worn out. So you're producing new red blood cells all the time. A statistic for you is they say you produce approximately 3 million red blood cells per second. And where erythropoiesis occurs is in the red bone marrow. The rate at which you produce red blood cells is controlled by a hormone called erythropoietin. What triggers you to produce more red blood cells is your blood oxygen levels. So what happens is if your blood oxygen levels drop, that gets detected by the kidneys. Okay, so the stimulus to produce more red blood cells is a drop in oxygen. The kidneys detect that and decide what to do, and they produce the hormone erythropoietin. So erythropoietin is your output. It's going to travel to the effector, and in this case the effector is your bone marrow tissue, and it tells the bone marrow to ramp up red blood cell production. So in response to that hormone, the red bone marrow starts to produce more red blood cells, so your hematocrit, or the number of circulating red blood cells, will increase, and therefore that would increase your oxygen carrying capabilities. So it's a little negative feedback loop. Now, erythropoietin was developed in labs artificially to give to people who were anemic. So a lot of cancer patients that have undergone chemotherapy, because remember, chemotherapy will wipe out any cells that are dividing in your body, and one type of cell that's dividing very rapidly is the stem cells in your bone marrow to produce more red blood cells. So it kind of wipes out your red blood cells when you undergo chemotherapy, and you could be anemic. So what they decided to do is produce erythropoietin outside of the body in a lab so that we can give it to these cancer patients. Well, guess what happened? Now EPO is being abused by athletes. The idea is if you have more red blood cells or a higher hematocrit, you have an increased oxygen carrying capability. And if you have an increased oxygen carrying capability, that means you can stay in aerobic respiration longer if you're an athlete. And if you can stay in aerobic longer and not go into anaerobic, your muscles are less likely to fatigue, or they fatigue slower, so you'll have an advantage. So like cyclists or marathon runners or any of those long distance endurance sports would benefit from increasing their oxygen capabilities. Another way that athletes used to try to stimulate red blood cell production somewhat naturally is they'd go and train at higher elevations. Because at higher elevations, the partial pressure of oxygen is lower, and so your oxygen levels in your blood are lower when you go up to a higher elevation. So that stimulates your body to produce EPO and increase your hematocrit. So after they're there for a while, they're hoping that they'll increase their red blood cells, and then when they go back to a regular altitude to complete their race, they'll have a higher red blood cell count. So that's a way athletes used to somewhat naturally try to stimulate their red blood cell production. But now some of them are using the drug EPO. So this is a little summary of the lifespan of a red blood cell. Well, you need iron because iron is part of the heme group and that carries the oxygen. So you get iron through your diet. It gets absorbed in the intestines and carried in the blood by a globulin protein called transferrin, and that transferrin will carry it to the bone marrow. And it's used to make the heme group, and combined with the proteins, it produces hemoglobin. So hemoglobin a lot of times is abbreviated HB. You'll see that. And that hemoglobin is used to make red blood cells. So when you make your red blood cell in the bone marrow, once it matures, it gets dumped into the blood and it starts circulating. And like we said, it will circulate for about 120 days and carry oxygen to and from the tissue, or to the tissues, and some carbon dioxide away from the tissues. And eventually, when he gets old and worn out, the spleen will destroy him, and he'll break the hemoglobin down, and the byproduct is what we call bilirubin. Now, bilirubin gets dumped back into the plasma, and your body needs to get rid of the bilirubin because it's a waste product. So how it gets rid of it is some of the bilirubin will go to the kidneys and get excreted in the urine. And bilirubin is yellow in color. It's a pigment, and so that's what gives your urine its yellowish color. And bilirubin will also go to the liver, and the liver will put it into bile, and that's what gives bile its yellowish color. Now, bile gets put into the intestines to help with fat digestion, so it gets eliminated from the body through your feces. Now, what happens is if bilirubin's allowed to accumulate in your body, if you're not getting rid of it fast enough, it produces what we call jaundice. So you'll get a yellow tint to your skin because the bilirubin is lipid soluble, and it will get into the hypodermis of the skin and turn you yellow, or the whites of your eyes will turn yellow if someone has jaundice. Some people will get jaundice because of liver failure. So people that have hepatitis or the cirrhosis of the liver or liver failure for some reason, their liver can't get rid of the bilirubin and they will get jaundice. Another population that tends to get jaundice is babies or newborn. And the reason there is when babies are born, they have what we call fetal hemoglobin, and that hemoglobin needs to be broken down and they'll start to make normal hemoglobin after they're born. If their liver is immature, like if they're born too early, if they're premature, or just their new liver or their young liver gets overwhelmed by this rapid breakdown of hemoglobin, it might not be able to keep up with the breakdown of the hemoglobin, so the bilirubin accumulates and they might get jaundice. There's many blood disorders, but one common one is anemia, and it's involved with the red blood cells. And anemia, the general definition of anemia is that it's just your blood has a decrease in oxygen carrying capabilities. There's over 100 different types of anemia depending on what's causing the decrease in oxygen capability. One of the main causes is you don't have enough red blood cells. We call that a low hematocrit. Another thing that can happen is you might have normal levels of red blood cells, but you're not producing enough hemoglobin to put into the red blood cells. So if you have a deficient amount of hemoglobin, or some people make abnormal hemoglobin, such as the case of sickle cell anemia, where they produce a different type of hemoglobin that folds funny and they can't carry as much oxygen. Other things is a deficiency in iron. That's a main cause of anemia. If you're deficient in iron, you can't produce the heme group for the hemoglobin. Or vitamin B12 also plays a role with the production of red blood cells. Kidney disease, because then you're not producing enough EPO or erythropoietin to stimulate red blood cell production. Obviously, some people can be anemic if they've suffered a large amount of blood loss, because they won't have enough red blood cells, because it takes a while to make to build the red blood cells back up after serious blood loss. Diseases such as malaria, and malaria is caused by a protist that is basically a parasite that infects the red blood cell and causes it to lyse or rupture. Now there's another thing called polycythemia, which is kind of the opposite. You have an increased number of red blood cells or hematocrit, so maybe you're producing too many red blood cells, which will cause your blood to be more viscous. So if you look at normal red blood cell percentages, we talked about if you took whole blood, about 55% should be plasma or fluid, and 45% is red blood cells. Now if you're anemic, you have less red blood cells, so if your hematocrit's less than 30, then you might be considered anemic, and you have more plasma. Now polycythemia is where your hematocrit might be too high. 70% of your blood would be red blood cells, 30% would be fluid. So what could cause you to produce too many red blood cells? One could be bone marrow cancers, where your cell division has increased and you're producing too many red blood cells. High altitudes, because we talked about the drop in oxygen, can stimulate an increase in your hematocrit. And then any lung and heart disease, because what will happen is if you have lung disease and you're not taking in enough oxygen, or heart disease where you're not pumping blood efficiently, your body might read that as the tissues aren't getting enough oxygen, and it might stimulate erythropoietin production. And then there is what is called relative polycythemia, where your red blood cell count might be normal, but when you look at it as a percentage of the whole blood, it's too high, because hematocrit is a percent. So if you look here, I have the same amount of red blood cells here as I do in normal, but the percent is different because I have lost some of my plasma. If you're dehydrated and you have less fluid, that makes the red blood cells be a higher percent of the total fluid. So dehydration causes what we call relative polycythemia. Alright, so now let's look at the role of your white blood cells, which we call leukocytes. Now leukocytes play a role in fighting against infection, and initiating inflammation. Inflammation is an important process for fighting infection and stimulating tissue repair. Now we're going to learn all about fighting infections and inflammation in our next lecture on body defenses and immunology. So for now, we just need to know your white blood cells play a role in that. White blood cells can also destroy cancer cells because they recognize damaged abnormal cells, and they play a role in repairing damaged tissue. Now if you look at a blood smear, which you probably did in anatomy, you can see all these little red dots are your red blood cells, and you have numerous red blood cells. And then you have very few white blood cells. We talked about that it's 1% of your whole blood is white blood cells, whereas 45% of your whole blood is red blood cells. So these prettier cells here, this guy, this large purple guy, and this guy here would be examples of white blood cells. And there's different types of white blood cells. There's neutrophils, eosinophils, basophils, monocytes, and then there's lymphocytes. There's T lymphocytes and there's B lymphocytes. So there's two types of lymphocytes. So let's look at, in general, what the general function is of these different types of white blood cells are. And we're going to be pretty brief on this. So you can divide leukocytes into two categories, granulocytes and agranulocytes. Granulocytes contain granules, and they tend to have a lobe nuclei. By lobe nuclei, we mean their nucleus isn't a nice round shape. It kind of has these lobes to it. You can see here, this one looks like it kind of has 3 different lobes. It's abnormally shaped. Or an eosinophil looks like it has 2 lobes to the nucleus. And then they look spotty. They have granules inside of them. Now an agranulocyte, if you put A in front of it, means without granules. So your 3 types of granulocytes are neutrophils, eosinophils, and basophils. Now the majority of your white blood cells are neutrophils. So I already told you only 1% of your blood is neutrophils, but out of that 1%, if you were to look at the different types of white blood cells, 60 to 70% of them would be neutrophils. And neutrophils are kind of the first on the scene of infection. So if you have an infection or tissue damage, neutrophils are kind of the first to get there because there's so many of them in your circulation. And they trigger inflammation. So they'll engulf, for example, bacteria, they're phagocytes. They'll engulf bacteria or damaged cell, and then they'll release chemicals. That's what their granules are. They're these chemicals, cytokines, that they release that trigger inflammation and attract other white blood cells to come to the area. Now eosinophils, you have a lot fewer of those. 1 to 4% are eosinophils. And eosinophils are pinker in color. They have like red granules in the cytoplasm. Their granules specialize in parasites, destroying parasites. They're also associated with allergies. So people that have allergies, you'll see that they have a higher percent of circulating eosinophils. And then basophils, you have very few of these. They stain a darker purplish blue color. And their granules are mostly histamine. And histamine is a chemical that when it's released, it triggers inflammation. It causes vasodilation of blood vessels. So it causes those cardinal signs of inflammation, which is redness, increased blood flow, swelling, itchiness. Histamine causes itchiness. Now your agranulocytes are your monocytes and lymphocytes, so without granules. And monocytes have a really large, they say, kidney bean or horseshoe-shaped nucleus. And they're macrophages, so they travel from the blood into the tissue, and they work as macrophages where they engulf pathogens or worn out cells or damaged cells. They're a cleanup crew, basically. And then lymphocytes are the second most numerous type of white blood cell after neutrophils. So you have about 25 to 33% of your white blood cells are lymphocytes. And as I said before, there's 2 types of lymphocytes, B cells and T cells. Technically we call them B lymphocytes or T lymphocytes. But lymphocytes have a nice round nucleus that takes up pretty much the entire cell. And they play a role in what we call specific immune defenses. Okay, and we're going to learn all about the role of B cells and T cells in our next lecture. They play a role in recognizing specific antigens that enter your body. We're going to really briefly talk about hematopoiesis, which is blood cell production. Now, if you're talking about red blood cell production, we specifically call it erythropoiesis. If you're talking about the production of white blood cells, you would call that leukopoiesis. If you're just talking about blood cell production in general, both red and white blood cells, you call it hematopoiesis. One thing you should be familiar with is that in your bone marrow you have stem cells. We call them a common stem cell. So you have a hematopoietic stem cell, and he can basically become any type of cell he wants, and he'll start to differentiate into the different types of cells. So all blood cells arise from this common stem cell found in the red bone marrow, and he can either go along the lymphocyte line to become a B or T cell, or he can go this route where you become all the other types of cells, your erythrocytes, your platelets, and then your neutrophils, monocytes, basophils, and eosinophils. Now there's numerous steps along these paths to become these cells. For example, they're showing a few of the steps for a red blood cell, and they're showing, okay, I'm an erythroblast, then I become a reticulocyte, and then I become a mature erythrocyte once I spit my nucleus out. There's actually more steps than this, and each step the cell is called something different. You don't need to worry about any of that. And you can see here they're showing, okay, I have a stem cell in my bone marrow. I go through the steps of red blood cell maturation, and then once it's a mature red blood cell, that red blood cell will enter into the blood and start circulating. Same with if I wanted to produce a neutrophil. I start as a stem cell, and I go through different phases of development to eventually become a mature neutrophil, and I'll be dumped into the blood. Now, platelets, we'll talk about, come from these cells called megakaryocytes. You can see this large megakaryocyte here dumping platelets into the blood. For now, all you need to know is that there is stem cells in your bone marrow that differentiate into all these different types of blood cells. I think it's about 2 weeks to make a red blood cell from the time it's a stem cell to when it becomes a mature erythrocyte. Okay, so here's a little summary of what blood is composed of. We talked about that blood is composed of plasma and then its formed cellular elements. We talked about what you would find in the plasma. It's mostly water, 90% water. You find some dissolved ions like sodium, potassium, some organic molecules. We talked about all the proteins you would find, your albumin, globulins, fibrinogen. But you'd also find, we didn't really mention this, but you know this, you would find obviously glucose circulating in the blood, lipids, nitrogen waste, amino acids, because your blood transports all these nutrients. And then you'd also find some gases. Some oxygen is dissolved in the blood, and carbon dioxide. And then we talked about your formed elements. We talked about red blood cells, or erythrocytes. We talked about your different types of white blood cells, or leukocytes. Remember, you have the lymphocytes, T and B, monocytes, neutrophils, eosinophils, basophils. Remember, these three, neutrophils, eosinophils, and basophils, are called granulocytes, and then lymphocytes and monocytes are categorized as agranulocytes. And then you have your platelets, which we haven't talked about much yet, so we're going to now talk about your platelets. Platelets, also known as thrombocytes, are not technically cells, but cell fragments. So I showed you in your bone marrow you have these really large cells called megakaryocytes, which also come from the same stem cells as all your other blood cells. And megakaryocytes fragment, basically they break into little pieces that become platelets. So these little fragments get dumped into the blood and start circulating. So platelets technically aren't a cell, they're a cell fragment. Some people still refer to them as a cell, but they're really small. So if you look at a blood smear, remember all these guys are your red blood cells, and then you have your pretty white blood cells with their lobe nuclei. These would be neutrophils with a really round nucleus, that's your lymphocyte, and a really big kidney bean shaped nucleus would be a monocyte, but those are all white blood cells. And then these little teeny purple guys over here are your platelets. Now, platelets' main role is it plays a role in stopping blood loss and blood clotting. So the process of preventing blood loss is called hemostasis. So when a blood vessel gets damaged or broken, blood can move out of the blood vessel. You can lose blood, therefore lose your blood volume, and your blood pressure will drop. One, you need to stop that blood loss, and you need to repair that blood vessel. So there's kind of 3 phases, and we'll go through each of these phases. The first phase is vascular spasm. Then you form what we call a platelet plug formation. You basically form a plug where that vessel is damaged with platelets. And then coagulation is the formation of the clot. So let's look at how you form your platelet plug formation. When a blood vessel gets damaged, remember in a blood vessel you have the endothelium, which is the epithelial cells, simple squamous cells, that line the lumen of the blood vessel. And underneath that, you're going to have collagen, right? Because you're going to have connective tissue underneath it. Now, when the epithelium gets damaged, that collagen gets exposed. And when that collagen gets exposed, it causes your platelets to become sticky. Because if a blood vessel isn't damaged, you do not want your platelets to be sticky. Because if you form platelet clots, okay, or clumps of platelets, they can get lodged in small vessels like your coronary arteries and cause myocardial infarction, or it can block small blood vessels in the brain, which can lead to a stroke. Okay, so it's dangerous to have clots and clumps of things floating around in your blood. So when a blood vessel isn't damaged, your platelets usually just move through the blood and they're not sticky. But when the collagen gets exposed because the blood vessel gets damaged, it causes the platelets to become sticky. Okay, and they cling together at the site of where the damage is. And then they release other chemicals that will attract more platelets to that area. So it's a positive feedback mechanism. So they secrete chemicals that attract more platelets. Some of the chemicals that they release are ADP, adenosine diphosphate. They also release chemicals that cause vasoconstriction of that blood vessel. Why would you want to vasoconstrict the blood vessel? Well, obviously you want less blood to flow to that area where the blood vessel is damaged so you can minimize your blood loss. So some of the chemicals it releases is serotonin, epinephrine, and then thromboxane A2 is a phospholipid found in the membranes of the platelets that cause vasoconstriction. Okay, so the platelets basically cling to the site and release a lot of chemicals that cause vasoconstriction and attract other platelets. Now, like I said, you only want to form a platelet plug in the area where the blood vessel is damaged. So how is that controlled? Okay, if these platelets are releasing all these chemicals, how do you not form one big platelet plug throughout the blood vessel? How do you keep the response localized where there's just damage? Well, what happens is where there's damage, where the collagen is exposed, you start to form the platelet plug. And these platelets are releasing ADP, which cause more platelets to become sticky. But what happens is in the nearby tissue where you have normal epithelium or normal endothelium, where the cells are still intact, these cells release chemicals like prostacyclin and nitric acid or nitric oxide, which is what NO stands for, nitric oxide. And these normal cells are releasing these chemicals that keep the platelets from becoming sticky and clumping together. So you have these normal cells releasing it to keep the platelets moving along, but just the area where there's damage with the platelets becomes sticky. Now, I talked about that the platelets will release a lot of chemicals that will cause vascular spasms, which is when the blood vessel constricts to diminish blood flow. So all this is happening together. It's hard to say what happens first, what happens second. Basically, the collagen gets exposed, the platelets start to release chemicals, the blood vessel constricts, and then you initiate what we call coagulation, which is the actual formation of the clot. So the platelet plug is kind of like a immediate temporary plug to try to prevent blood loss. Then you got to form more of a stable, more permanent structure, which will be your clot, and that's called coagulation. So you need to form a network of fibers that seals the blood vessel off until the epithelium and the connective tissue underneath the clot can repair itself. And coagulation involves what we call the clotting cascade. So let's look at the clotting cascade. Now this is my very general summary of what happens in the clotting cascade. There is 12 clotting factors that play a role. So I'm telling you what's needed for the clotting cascade to occur. You need your 12 clotting factors, which are circulating in the blood. Okay, they're already there, circulating in the blood, but they're not activated until a blood vessel is damaged. You also require the presence of calcium, because calcium is a cofactor in activating these clotting factors. And then there's what's called platelet factor 3, which is released by the platelets. So that's kind of the role the platelets play in initiating the clotting cascade. They release this platelet factor that helps. And what basically happens is you have all these clotting factors in the blood, but they're inactive. And when collagen gets exposed because of a damaged blood vessel, that activates the first clotting factor in the cascade. And once you activate the first one, he then activates the next one, and so on, because it's a cascade, until you get to your final step, which is thrombin converts an inactive protein called fibrinogen into fibrin. And fibrin is the actual fiber that structurally forms the clot. It's a cascade. One thing gets activated, who activates the next, and the next, and the next, and the next, until you get to activating thrombin, which converts fibrinogen into fibrin, and fibrin is your clot. Now let's look at it in a little more detail. So these are the events of your clotting cascade. You have both what we call an intrinsic pathway, which happens within the blood vessel, and you have your extrinsic pathway, which gets activated outside of the blood vessel. So this is the cascade. There's 12 factors. Now, wouldn't it be easy if factor 1 activated factor 2, which activated factor 3 in numerical order? Of course that would be easy. But the factors weren't named for the order that they occur in the cascade. They were named in the order that they were discovered. So it's not numerical. So it makes it a little more difficult to memorize the clotting cascade. Like I said, you have all these factors. It starts with factor 12, factor 11, then it goes factor 9, factor 10, that's where it gets out of order. Okay, factor 2, factor 1. All these clotting factors are proteins that are in the blood. They're inactive. Basically, they're not triggering a clot to form when the blood vessels are healthy. But you want them to be inactive, because if they get activated when there isn't a damaged vessel, you'll get a clot that forms in a healthy vessel. And like I said, that's called a thrombosis. And if that thrombosis starts moving, it's called an embolism, where it starts traveling through the blood. Like I said before, that's very, very dangerous, because if that clot gets lodged in a small vessel of the heart or the brain, it could cause heart attack or a stroke. Okay. Now, some people have clotting disorders where they spontaneously form clots, and it can be dangerous. So these inactive proteins are traveling in the blood. A blood vessel gets damaged, the collagen gets exposed, and that's the trigger to activate what we call factor 12. Another name for factor 12, I call it Hegmann factor. So Hegmann factor gets activated by the exposed collagen. He then acts as an enzyme to activate the next factor in the cascade, which is factor 11. And then factor 11 activates factor 9. And then factor 9 activates factor 10. Factor 10 activates what we call prothrombin into thrombin. And this is that final step we talked about. Thrombin then activates fibrinogen into fibrin, and fibrin's what makes up your clot. We mentioned that calcium's important. Here's where calcium comes in. And we talked about the PF3, platelet factor 3, is a cofactor in these steps. Now, fibrin, it kind of forms a loose meshwork, and eventually has to get stabilized or tightened up. So there's another factor here, factor 13, that causes the fibrin to tighten up and form a nice tight clot. Now you might be like asking, oh my gosh, do I have to know this whole pathway? Well, the answer there is no, but you have to know most of it. I'm not going to ask you to tell me where calcium plays a role or exactly which step PF3 plays a role in, but you do need to know that calcium and PF3 are required. Okay. What you need to know for sure. You need to know the first step. You need to know that the damaged vessel activates factor 12 or Hagman factor. And then Hagman factor activates the next guy. That's all you need to know. But then you need to know this last part here. You need to know that factor 10, okay, and factor 10 is going to activate prothrombin into thrombin, and you need to know thrombin activates fibrinogen into fibrin. So you need to know what triggers the pathway, and these last steps of that thrombin then activates fibrin to give you your clot. So pretty much everything. You don't have to know this little part here, or you don't have to know, factor 13 here, but almost all of it. Now, there also is what's called the extrinsic pathway, and this is kind of interesting. What happens is the clotting cascade can also be initiated when not necessarily a blood vessel is damaged, but when tissue is damaged. Okay? So when you have significant tissue damage, the damaged tissue will release what we call thromboplastin, and it's called the extrinsic pathway. Now, thromboplastin can diffuse into the blood and trigger the pathway from factor 10 on. So from factor 10, there's overlap. So you can see how on this diagram it's showing that you then have overlap of this last part. So thromboplastin, which is released by the damaged tissue, will activate factor 10, which then activates thrombin, which activates fibrin. So you need to know the extrinsic pathway. It involves the thromboplastin. Now this is kind of looking at a closer up role of this last step and the role of thrombin. We say that the clotting cascade is a positive feedback that's eventually self-limiting. Where it becomes a positive feedback is here in the thrombin. Because thrombin, we just learned, converts the fibrinogen into fibrin. But the other thing thrombin does is it activates this factor 13, which helps stabilize your fibrin meshwork, stabilize the clot. But then he also creates this positive feedback, because when you produce some thrombin, he actually goes back and activates more prothrombin into thrombin. And then the other thing thrombin does is he attracts more platelets. And the platelets release the platelet factor 3, which played a role in the clotting cascade. So basically you're enhancing the whole entire clotting cascade. So after you form your fibrin clot, what's going to happen? Well, you have what we call clot retraction. And this is that last step where the meshwork tightens up. And the platelets get trapped in that meshwork when the fibrin gets formed. And some red blood cells will get trapped too. So you have these fibers and all the cells trapped there in the clot. And platelets have a little bit of actin and myosin in them, and they actually contract. And the fibrin squeezes together, and it kind of squeezes the serum out, the fluid that might be trapped in that clot. It also kind of pulls the edges of the blood vessel together. The purpose of that clot is it's kind of like an internal scab, I think of it. You damage your epithelium on the outside of your skin, you get a scab that's over it. And the purpose of that scab is to protect the tissue underneath that's damaged until it repairs itself. So while that scab is there, the epithelium underneath is starting to regrow and repair. And once it is regrown and repaired, then the scab can come off. Well, that's what a clot is. It's like an internal scab for your blood vessel. So you have damaged endothelium and connective tissue of the blood vessel wall. So the clot forms over it, and it stays there while the vessel repairs itself underneath the clot. So you have to repair that vessel. So platelets that are trapped in the clot will also release chemicals that attract the fibroblasts. So do you remember what fibroblasts were from anatomy? Fibroblasts are found in your connective tissue, and they produce collagen. Okay. So fibroblasts will help produce collagen to repair the blood vessel wall, and the endothelium will just divide to repair itself. Endothelium repairs itself pretty well. And then once that vessel gets repaired, you now need to get rid of your clot. So you have what you call clot dissolution. Thrombin not only does positive feedback of forming the clot, but then he also plays a role in breaking down the clot, which is odd, but he does. And then there's this guy called tissue plasminogen activator, TPA. So this guy, you should remember him. And tissue plasminogen activator, what he does is he activates a protein that's also found in your blood called plasminogen. So once a clot forms and once the endothelium has repaired itself underneath, chemicals are released called tissue plasminogen activator. And tissue plasminogen activator will activate plasminogen into an enzyme called plasmin. And plasmin is an enzyme that then breaks down the fibrin. Okay, so plasmin starts to break up your clot. And that's your clot dissolution. Now what's interesting is they now use TPA, or they've formed drugs that mimic TPA. Because in people that form clots spontaneously, or people that might be having a stroke or a heart attack, they can give you TPA, a drug that mimics TPA, and they hope that it will break down that clot and allow blood flow to return to that area. Alright, so you just learned about the clotting cascade. And there's a lot of spots where things can go wrong, and if any of those factors aren't there or aren't functioning properly, you can get a clot disorder. We kind of talked about a thromboembolism. This is when a clot forms when it doesn't necessarily need to in an intact vessel. Now what can cause that to happen? Well, you might just have some sort of imbalance between your clotting factors and your anti-clotting mechanisms. So maybe it could be an imbalance in any of these factors, or it might be that you can't break your clot down, or it could be all the way back. Let's go back to, remember your platelets. Maybe it's that your normal endothelium isn't producing enough prostacyclin and nitric oxide. So if it's not inhibiting the clotting well enough. Okay, so that's what I mean by maybe the clotting factors are too active, or maybe your anti-clotting mechanisms aren't active enough. The other thing is if blood sits for too long, it can initiate clotting. So slow-moving blood, that's where sometimes like varicose veins can become dangerous if blood sits there too long. Or you guys know probably that if you have surgery or if you're bedridden for a long time and you're not moving, they try to circulate. It's very important that you keep someone's blood circulating, like you massage their legs, or they have those little sock things that they put on hospital patients to keep the blood circulating, because you don't want the blood to clot. Now the other thing that can happen is sometimes when people suffer trauma or tissue gets damaged, like if you have surgery, sometimes after surgery you're at a higher risk for forming clots. Or if you just have, you get in a car accident or anything where you might not be hemorrhaging, but later on you start forming clots spontaneously. If tissue gets damaged, you might release a lot of this thromboplastin, and sometimes that thromboplastin can then diffuse into the blood and trigger this clotting cascade. Okay, so the release of thromboplastin from damaged tissue. All right, then there's some genetic clotting disorders, such as hemophilia, and you have a deficiency in one of the clotting factors, so genetically they don't produce one of the clotting factors. There's two types of hemophilia, hemophilia A and B. It's usually they're missing clotting factor 8. But the other type is where you're missing, it's usually clotting factor 9. Okay, so 8's the most common, 9's the second. But technically, genetically, you could be missing any of the 12 factors, and that clotting cascade will be halted. And that can trigger excessive bleeding. And that's usually genetic. Then there's what's called thrombocytopenia, which is a deficiency in platelets. You don't produce enough platelets. And then the other thing is anyone who has an impaired liver will a lot of times have clotting disorders because all of those clotting factors are produced in the liver. And then there's vitamin K. Vitamin K plays a role in producing these clotting factors in the liver. So if you have lack of vitamin K, you might not be able to. Now on some people who are taking anticoagulants, some people take like Coumadin to keep their blood from clotting because they clot too much. They're told to not eat or to remove vitamin K from their diet or not eat things high in vitamin K because Coumadin, the way that it is an anticoagulant, is it blocks the use of vitamin K to make the clotting proteins. And so if you then take a bunch of vitamin K in, you can counteract the Coumadin. Here's just a general summary of the clotting cascade. So if you have damage to the vessel wall and how there's overlap between the platelet plug and the coagulation and the vasoconstriction. So you have damage to the blood vessel wall, collagen gets exposed. That's going to initiate the platelet plug. Now the collagen exposure also stimulates the coagulation cascade because it activates your first factor 12, which eventually leads to thrombin formation and fibrinogen being converted to fibrin. Now we also learned that the clotting cascade through the thrombin causes more platelets to aggregate. So it's just kind of showing you your platelet plug and your vasoconstriction, which is caused by the platelets releasing their chemicals, is kind of a temporary hemostasis. It minimizes the loss of blood immediately. And then a more, not permanent, but a more long-term solution is you eventually get your clot, your fibrin, and your platelet plug, which blocks that blood vessel until it can repair itself, and then you have to break your clot back down. Alright, so that's blood. Pretty much you just need to know what blood's made of, plasma, what the role of the proteins are in the plasma, and then your different types of cells, such as your red blood cells, what their function is, white blood cells, what all the different white blood cells do, the platelets, and then knowing your clotting cascade, the intrinsic pathway and the extrinsic pathway.